Welcome to The Explainer. Today, we are so excited to be diving into a really powerful update on diabetic kidney disease, breaking down the key insights from Dr. Kevin Ganong's presentation at the recent 2025 ADEEF St. Bernard's Symposium. This is a must-know for all of us healthcare providers. So let's kick things off with a number that really just frames the problem. Back in 2019, here in the US, we had more than 300,000 patients with end-stage renal disease, specifically from diabetes. This isn't some small niche issue, it's a massive public health challenge. And here's the real kicker, the thing you probably see in your own practice every day. It's not just the sheer number of patients. It's that most of them have absolutely no idea their kidneys are in trouble until things are already very, very advanced. This chart just drives that point home. It perfectly illustrates the scale of this awareness gap. I mean, think about the patients with diabetes on your panel right now. According to Dr. Ganong's data, for every 10 of them who have chronic kidney disease, a staggering 9 of them don't even know it. So what happens when you have this huge diagnostic gap? Well, you get a silent but steadily growing threat. And the consequences of catching this late are severe, affecting the whole patient, not just their kidneys. And look, the reason this matters so much isn't just about trying to keep patients off dialysis way down the road. Diabetic kidney disease is the #1 cause of end-stage kidney failure on the planet. But even in its earliest stages, it sends all-cause mortality way up and just cranks the risk for major cardiovascular events. We're talking heart attacks, strokes, heart failure, through the roof. Okay, so we see the consequences. But how does this damage actually happen? Let's pop the hood and take a look at the pathophysiology to really understand what's going on inside the kidney and, who's most at risk. Dr. Ganong laid out this really clear cascade of events. It all kicks off with an increase in ROS. That's the renin-angiotensin-aldosterone system, which messes with the pressure inside the glomerulus. This leads to this damaging state called hyperfiltration, which in turn causes actual structural injury and the loss of this critical podocyte cells. So when you're looking at your patient list, who should be on your high alert radar? Well, here's your checklist. You've got the usual suspects we all know: high blood sugar, systolic blood pressure over 140, obesity. But Dr. Ganong really stressed to pay close attention to any history of acute kidney injury and, importantly, the presence of retinopathy. That's a huge predictor. And, this is interesting. The data also points to a pretty clear gender disparity. The hazard ratio for males is 1.37, which tells us that men face a significantly higher risk of developing diabetic kidney disease. And then there's this number, which is frankly staggering. Patients with low socioeconomic status have a 4- to 5-fold higher risk. Dr. Ganong really emphasized that this huge gap isn't just explained by ethnicity. It points to much deeper systemic factors that we have to be aware of. All right, so with all that context, let's pivot and bring this right back into the clinic. How should we be evaluating our patients? Dr. Ganong shared several key clinical pearls that can really change how you practice. The guidelines from the ADA and KDIGO are pretty straightforward on this. Screen every year with both an eGFR and a urine albumin. For type 2 diabetes, you start right at diagnosis. But here's the crucial pearl. If you get a positive screen, you have to repeat the test within 3 months to confirm it's a real persistent problem.
Okay, here's a question that really challenges a piece of clinical dogma that many of us were taught. We instinctively connect diabetic kidney damage with lots of protein spilling into the urine, right? But is that always the case?
And boom, here it is. This is the game-changing pearl from Dr. Ganong you absolutely have to take home. Up to 52%, more than half, of patients with type 2 diabetes can progress all the way to end-stage kidney failure without significant proteinuria. It means if you're only looking for that one marker, you are going to miss a massive number of patients at risk. It's a trap. So after all that, this is where the story gets really, really hopeful. The treatment landscape for DKD has been completely revolutionized. So once you find out, what do? Let's walk through the modern treatment playbook. First things first, the cornerstone of therapy is still what it's always been: aggressive blood pressure control. This is non-negotiable. We're targeting a systolic below 130, and our first-line agents are still an ACE inhibitor or an ARB. It's fundamental for slowing progression and slashing that cardiovascular risk. Now, on top of that foundation, we have what we can think of as 4 proven pillars of modern therapy. We've got SGLT2 inhibitors, GLP-1 agonists, a newer agent called Finerenone, and even good old Metformin. All of them have solid evidence showing they reduce the risk of DKD progression. Okay, so when you're looking at the two heavy hitters here, how do you choose? Well, it often comes down to the patient sitting in front of you. For your patients who also have heart failure, an SGLT2 inhibitor is absolutely the preferred choice. But for those with severe obesity and a really high A1C, the data points towards starting with a GLP-1 agonist.
Now, let's talk about metformin for a second, because its role in all this has been a real roller coaster. After a pretty disappointing study back in 2015, the story has completely flipped. A huge observational study in 2025 showed a clear protective effect at all stages of kidney function, which has swung the pendulum right back in its favor.
And all of this really leads us to one final exciting question. With these four powerful classes of medication at our disposal, the goal is actually shifting. We're moving beyond just slowing the decline to maybe, just maybe, preventing kidney failure altogether in our patients with diabetes. What a fantastic place to be. Thanks so much for joining this explainer.